That nagging feeling, right? You're doing everything, well, right, the diet, the exercise, sleep, but something's just off.
Exactly. We had a listener ask about this, and it really points towards conditions like Graves' disease, which is our focus today.
Yeah, we're diving deep. We've got this great set of detailed notes covering, well, pretty much everything about it.
Definition, causes, symptoms, how it's diagnosed, treated, the works. We're going to sort of guide you through the really crucial bits.
Our mission, to pull out the key info on Graves. We want to shed some light on this because it's common, but, often misunderstood. Maybe help connect the dots for you or someone you know.
Aiming for those aha moments.
Definitely. So let's start with this. Have you ever felt like your body was kind of working against you, even when you felt like you were doing everything right?
Okay, so let's lay the foundation. What is Graves' disease? Fundamentally, it's an autoimmune disorder.
Autoimmune, meaning your own immune system messes up.
Precisely. Your defense system mistakenly attacks your own healthy tissue. In Graves's, the target is the thyroid gland.
And that leads to hyperthyroidism, right? An
Mm,
overactive thyroid.
exactly. And it's actually the most common cause of hyperthyroidism. The notes say, what, 60 to 80% of cases? It's significant.
Wow, that many. And it's not a new thing either. I saw it was named after Robert Graves, an Irish doctor, way back in 1835. A little bit of history there.
That's right. Now, the how is fascinating. It involves these things called autoantibodies, specifically thyroid-stimulating immunoglobulins, or TSI.
Okay, TSI, so what do they do?
Well, think of them as like imposter molecules. They mimic the body's normal signal, TSH, thyroid-stimulating hormone, which tells the thyroid what to do.
Ah,
But TSI binds to the same receptors on the thyroid as TSH does, only instead of a normal signal, it's like they jam the accelerator pedal down constantly.
so these rogue antibodies are essentially tricking the thyroid into going full throttle all the time,
Okay.
pumping out way too much T3 and T4, the thyroid hormones.
You got it.
I-
And because the body senses all this extra hormone floating around, the pituitary gland says, whoa, too much, and stops sending out its own TSH signal.
Which is why you see low or suppressed TSH levels in the blood tests for Graves. The natural control system is trying to shut down, but the TSI antibodies are overriding it.
It's like a faulty thermostat, yeah. Telling the furnace to keep blasting heat even though the house is already boiling.
Makes sense. And what causes these TSI antibodies to show up in the first place? Is it random?
Not entirely random, usually. The notes point to a combination of factors. There's often a genetic predisposition.
Like you inherit a tendency towards it?
Yeah, certain immune system genes like HLA-DR3 and CTLA4 are mentioned as examples. Having these doesn't guarantee you'll get Graves, but it increases the susceptibility.
Okay.
But it's usually genetics plus something else. Environmental triggers seem to play a big role too.
Triggers like what?
Things like major stress, certain infections, even smoking is a known risk factor, particularly for the eye problems associated with Graves, which we'll get into.
Interesting. So it's that combination again. Genetics loads the gun, environment might pull the trigger. Kind of a useful way to think about it, maybe?
That's a decent analogy, yeah. It highlights that interplay. So thinking about that, have you or someone you know noticed feeling off after a period of high stress or maybe after an illness? Worth considering.
Definitely food for thought. Okay, so if Graves is developing, what kinds of signs or symptoms should people be aware of? The notes break this down, right? General hyperthyroid stuff and then Graves-specific things.
Exactly. Let's start with the general signs of just having an overactive thyroid, regardless of the cause. One of the really classic ones is weight loss, even though you might be eating more or have an increased appetite.
That sounds counterintuitive and probably quite alarming for someone experiencing it.
It really can be. It reflects that super revved up metabolism.
Right.
Along with that, feeling hot all the time, heat intolerance, and sweating excessively are very common.
Like your internal thermostat is just stuck on high.
Pretty much. And then there are the heart effects. Palpitations, feeling your heart pounding, or racing a fast heart rate, which doctors call tachycardia. And importantly, there's a higher risk of developing arrhythmias, like atrial fibrillation, which is an irregular and often rapid heart rhythm.
Okay, so serious cardiovascular implications there. What about mood and energy?
Big impact there too. Anxiety, irritability, trouble sleeping, maybe insomnia. And you might notice tremors, like a shakiness, especially in your hands.
This is miserable.
And confusingly, you can feel really fatigued, just wiped out, and have muscle weakness, particularly in the muscles closer to the center of your body, like upper arms and thighs. This is sometimes called proximal myopathy.
Tired but wired and weak. What a combination.
It's a very frustrating mix for people. Add to that potential digestive issues, more frequent bowel movements, maybe diarrhea. And for women, periods can become irregular, lighter, or even stop altogether.
So a huge range of possible symptoms just from the hyperthyroidism itself.
A really wide range. But now, let's talk about the features that point more specifically towards Graves' disease being the underlying cause. These are sort of the distinguishing clues.
Right, the things that make you think, this looks more like Graves. I guess the eye problems are a big one. Graves' ophthalmopathy or thyroid eye disease, then?
That's probably the most well-known specific feature. What happens is that those same autoantibodies that attack the thyroid can also target the tissues behind and around the eyes, the muscles, the fat, the connective tissue.
And what does that look like?
It can cause inflammation and swelling back there, which pushes the eyeballs forward. That's called proptosis, or exophthalmos, the bulging eye appearance.
That sounds quite dramatic.
It can be visually. You might also see lid retraction, where the upper eyelid pulls up higher than normal, showing more of the white part of the eye above the iris. And lid lag, when someone looks down, the upper eyelid doesn't follow the eyeball smoothly, it lags behind.
Subtle signs, maybe, but a doctor would pick up on them.
Potentially. And beyond the appearance, there can be puffiness around the eyes, periorbital edema, and redness or irritation of the conjunctiva. More concerning is double vision, diplopia, if the eye muscles become inflamed and don't work together properly.
Double vision would certainly get your attention.
Absolutely. And here's the critical part in severe cases. The swelling behind the eye can compress the optic nerve. This is called optic neuropathy, and it can lead to vision loss if not treated urgently.
Wow. Okay, so the eye symptoms are definitely not just cosmetic. They can be serious.
Very serious potential complications. It really underscores why getting a diagnosis is so important.
Are there other Graves-specific signs?
Yes, though less common than the eye issues. There's a skin condition called Graves' dermopathy or pretibial myxedema. It usually shows up as thickened, sort of reddish-brown, lumpy skin, typically on the shins. It's quite distinctive when it occurs.
Okay.
And even rarer is something called thyroid acropathy, which involves clubbing of the fingers and toes, similar to what you might see in some lung conditions, along with swelling. Very uncommon, though.
Got it. And we shouldn't forget the goiter itself, the enlarged thyroid. In Graves's, it's typically smooth and affects the whole gland, right? Diffuse goiter.
Yes, a diffuse, often symmetrical enlargement. And because the gland is so overactive and has so much increased blood flow, a doctor listening with a stethoscope might hear a bruit, a kind of whooshing sound.
Like a vascular hum.
Exactly. All these clues together, the general hyperthyroid symptoms plus maybe eye signs or the specific type of goiter, start building the picture for a diagnosis.
Which brings us to the next logical step. How do doctors actually confirm it is Graves' disease? You mentioned blood tests earlier.
Right. Blood tests are absolutely key. The first thing you look for is that pattern. Very low or undetectable TSH, combined with high levels of free T4 and/or free T3. That confirms hyperthyroidism.
Okay, that tells you the thyroid is overactive. But how do you know it's Graves is causing it?
That's where the antibody tests come in. Testing for TSI, those thyroid-stimulating immunoglobulins, is the most specific test for Graves's. If those are positive, it's pretty much diagnostic.
So TSI is the smoking gun, so to speak.
In most cases, yes. You might also test for anti-TPO antibodies. They're often positive in Graves too, but they're also positive in Hashimoto's thyroiditis, the autoimmune cause of hypothyroidism. So they aren't as specific just for Graves.
Okay, TSI is the key one. What about imaging? Do scans help?
They can be very helpful, yeah. A thyroid ultrasound is often done. It can show if the gland is diffusely enlarged, and Doppler ultrasound can show that increased blood flow we mentioned, sometimes called the thyroid inferno, because it looks so dramatic on the scan.
Thyroid inferno. That's a vivid description.
It really captures it sometimes. The other main imaging test is the radioactive iodine uptake scan, the RAIU.
How does that work?
You take a small, safe dose of radioactive iodine, usually as a capsule. The thyroid naturally takes up iodine to make hormones. The scan then measures how much iodine your thyroid absorbs and where. In Graves, because the whole gland is being stimulated by TSI, you typically see a high uptake spread evenly throughout the entire gland.
And that pattern helps differentiate it from other causes of hyperthyroidism.
Exactly. For example, if someone had a single hyperactive nodule, you'd see high uptake just in that spot. Or in some types of thyroiditis, inflammation might actually cause low uptake. So the RAIU pattern is another important diagnostic clue.
Right, putting all the pieces together, symptoms, blood tests, imaging. Okay, so Let's say the diagnosis is confirmed, Graves' disease. What happens next? What are the treatment options?
There are basically three main lines of treatment aimed at controlling the overactive thyroid. First, there are antithyroid drugs, or ATDs.
Medications to slow the thyroid down.
Yep. The main ones are methimazole or carbimazole, which gets converted to methimazole in the body, and propylthiouracil, or PTU. They work by blocking the enzyme that helps make thyroid hormone.
Is one preferred over the other?
Generally, methimazole is the first choice. It tends to work well, can often be taken once a day. PTU is usually reserved for specific situations, like the first trimester of pregnancy or in a thyroid storm, which is a rare but severe hyperthyroid emergency.
Okay. And these drugs cure it or just manage it?
They manage it. They control the hormone production while you're taking them. Some people go into remission after a course of treatment, maybe 12, 18 months, and can stop the medication, but relapse is common. Others might need longer-term treatment.
Are there downsides, side effects?
There can be. Minor side effects like rashes or joint pain can occur. More serious, but much rarer, are things like liver problems, especially with PTU, or a condition called agranulocytosis.
Agranulocytosis, what's that?
It's a sharp drop in certain white blood cells that fight infection. It's rare, maybe 1 in 500 people, but serious. Patients are usually counseled to stop the drug and seek immediate medical attention if they develop a fever or sore throat. Requires monitoring.
Good to know. Okay, so drugs are one option. What else?
The second option is radioactive iodine therapy, RAI. We mentioned the RAIU scan for diagnosis. This uses a higher dose of the same radioactive iodine, I-131.
But actually destroy the thyroid tissue.
Exactly. The thyroid cells absorb the iodine, and the radiation selectively destroys those overactive cells over a period of weeks to months. It's usually a single dose, taken as a capsule or liquid.
That sounds more permanent.
It is generally considered a permanent fix for the hyperthyroidism, but there are important considerations. It's absolutely not used during pregnancy or breastfeeding.
Right.
And it can potentially worsen Graves' eye disease, especially if it's already moderate to severe. Sometimes doctors give steroids around the time of RAI treatment to try and prevent that.
Okay. And what's the main long-term outcome of RAI?
Because it destroys thyroid tissue, the most common outcome is developing hypothyroidism and underactive thyroid, usually within months, but sometimes years later.
So you trade one problem for another, in a way.
In a way, yes. But hypothyroidism is generally considered easier and safer to manage long-term with daily thyroid hormone replacement pills, levothyroxine, than uncontrolled hyperthyroidism. Still, it means lifelong medication for most people after RAI.
Okay, that's a significant trade-off to understand. What's the third main option?
Surgery. A thyroidectomy, which is the removal of most or all of the thyroid gland.
When would surgery be the choice?
It might be preferred if someone has a very large goiter that's causing compression symptoms, like trouble swallowing or breathing, or if there's a suspicious nodule within the thyroid that might be cancerous. Also, sometimes it's chosen if someone can't tolerate the drugs, doesn't want RAI, or if they want a quicker, more definitive resolution of the hyperthyroidism, perhaps before planning pregnancy.
Are there risks with surgery?
Like any surgery, yes. The main specific risks are damage to the parathyroid glands, which sit right behind the thyroid and control calcium levels. Damage can lead to hypoparathyroidism and the need for calcium and vitamin D supplements. There's also a small risk of injury to the recurrent laryngeal nerves, which control the vocal cords, potentially causing voice changes or hoarseness. Experienced surgeons minimize these risks, but they exist.
And after surgery, you definitely become hypothyroid.
If the whole gland is removed, yes, you'd need lifelong levothyroxine replacement, just like most people after RAI.
So drugs, radioactive iodine, surgery, each with pros and cons. Are there other things used alongside these?
Definitely. Adjunctive therapies are really important for symptom control, especially early on. Beta blockers, like propranolol or etanol, are often used right at the start.
What do they help with?
They don't affect the thyroid hormone levels directly, but they block the effects of adrenaline, which is ramped up in hyperthyroidism. So they quickly help control symptoms like rapid heart rate, palpitations, tremors, and anxiety while waiting for the main treatment to work.
Immediate relief. Makes sense. What about for the eye disease?
For moderate to severe Graves' ophthalmopathy, high-dose glucocorticoids like prednisone are often the first-line treatment to reduce the inflammation and swelling behind the eyes. Other specialized treatments might be needed too.
And you mentioned selenium earlier.
Yes, some studies suggest selenium supplements might be helpful for mild eye disease. The evidence isn't super strong, but it's sometimes recommended, possibly for its antioxidant effects.
Okay. So managing Graves' seems quite multifaceted. Now, what happens if it's not managed well? What are the big risks or complications?
Well, as we touched on, thyroid storm is the most acute and dangerous complication. A sudden, severe worsening of symptoms that's life-threatening and needs emergency treatment.
That sounds terrifying.
It is thankfully rare with treatment. Long-term uncontrolled hyperthyroidism puts a huge strain on the heart, increasing the risk of atrial fibrillation, which itself raises stroke risk, and potentially leading to heart failure.
The cardiac risks seem really significant.
They are. Also, chronic high thyroid hormone levels accelerate bone turnover, which can lead to osteoporosis and increased fracture risk over time.
Weak bones, too.
And we already discussed the potential complications of Graves' ophthalmopathy, corneal ulcers from exposure if the eyes bulge badly, and that risk of optic nerve compression and vision loss. Plus, of course, the risk of eventually becoming hypothyroid after RAI or surgery.
So getting that diagnosis and sticking with the management plan is absolutely crucial.
Absolutely critical.
The notes also mention specific situations, like pregnancy. You said PTU is preferred in the first trimester.
That's right. Methimazole has a slightly higher association with certain birth defects when used early in pregnancy, so PTU is generally the go-to for the first trimester if medication is needed. Often, doctors switch back to methimazole later in pregnancy if control is still required.
And the baby needs monitoring, too.
Yes, because those TSI antibodies can cross the placenta. In some cases, they could potentially stimulate the baby's thyroid, causing fetal or neonatal hyperthyroidism, so monitoring is important.
Good to know. And the smoking link, just to reiterate, smoking makes the eye disease worse.
Unequivocally, yes. Smoking is a major risk factor for developing TED and for having a worse course if you do develop it. Quitting smoking is one of the most important things someone with Graves', especially with eye signs, can do.
A really strong message there.
Yeah.
Okay, so looking at the bigger picture, what's the general outlook, the prognosis for someone diagnosed with Graves' disease?
Overall, the prognosis is generally very good if the condition is diagnosed and treated appropriately. People can live full, normal lives.
That's reassuring.
It is. The main caveats are the potential for relapse, especially after stopping antithyroid drugs, maybe around a 50% chance, sometimes higher, and the need for lifelong monitoring.
Monitoring for what exactly?
Either for recurrence of hyperthyroidism if treated with drugs, or for the development or management of hypothyroidism if treated with RAI or surgery. And regular checks for eye disease are important too, so it's a long-term relationship with your healthcare provider, usually.
Okay, so let's try and sum this up. Graves' disease. It's autoimmune, causes hyperthyroidism, has those specific features like eye issues, maybe skin changes.
Right. Diagnosis involves blood tests, TSH, T4, T3, and especially TSI antibodies, plus imaging like ultrasound and sometimes RAIU scans.
And treatments are antithyroid drugs, radioactive iodine, or surgery, often with beta blockers for symptoms initially. Each has its own profile, risks, benefits.
And often leads to needing lifelong thyroid hormone replacement eventually, especially RAI and surgery. Early diagnosis, consistent management, absolutely key to avoiding serious complications like thyroid storm, heart problems, bone loss, or vision issues.
So for you listening, if this deep dive resonated, if those symptoms sound familiar, if that feeling of being off despite doing the right things hits home, or if you recognize this in someone else, please, this isn't medical advice, but take this information to your doctor.
Use it to start a conversation.
Shake.
Don't self-diagnose, but do advocate for yourself. Get things checked out properly.
Absolutely. And, thinking about all this, the genetics, the environment, the immune system going rogue, it really makes you wonder, doesn't it?
How so?
Well, it prompts a broader thought. Given this complex interplay in Graves', what other connections might exist between seemingly unrelated things, stress, infections, maybe even diet or gut health, and the way our immune systems behave overall? What does this tell us about how intricate our health really is?
That's a fantastic point. The complexity of autoimmune conditions like Graves' really does open up big